Hello, beautiful souls. Welcome back. I am thrilled to have you join us today for a crucial conversation on varicose veins. Don't forget to hit that subscribe button and ring the notification bell, because knowledge is power, and together, we can make a difference. Now, let's get started. Varicose veins is a venous insufficiency syndrome where there is dilated, tortuous veins of the subcutaneous/superficial venous system where there is no proper venous flow. Venous blood deviates from a normal flow path and flows in a retrograde direction so that blood accumulates, causing a congested leg. The condition is commonly seen in lower limbs. Chronic venous insufficiency leads to venous hypertension. First, let's talk about the anatomy of the venous system. There are two venous systems found in the lower extremity, deep and superficial. The deep system leads back to the inferior vena cava, and then to the heart. The superficial system is found above the deep fascia of the lower extremity, within the subcutaneous tissue. Many superficial veins exist, but they all drain into the two largest, the great saphenous vein and the small saphenous vein. Multiple perforating veins, for example, Dodd's perforator, Boyd's perforator, Cockett's perforator, medial gastrocnemius perforator, and fibular perforators, transverse the deep fascia of the lower extremity and connect the great saphenous vein to the deep veins. The great saphenous vein joins the common femoral vein, located proximally at the groin, which is called the saphenofemoral junction. The saphenopopliteal junction is located behind the knee, where the small saphenous vein joins with the popliteal vein. In healthy veins, one-way valves direct the flow of blood through the superficial system into the deep system up the leg and toward the heart. Disruption in the unidirectional flow of blood toward the heart results in ambulatory venous hypertension. The pathophysiology as to why varicose veins develop. Incompetence of valves at any location, for example the greater or lesser veins, saphenofemoral junction, saphenopopliteal junction, perforators of the venous system, or the blockage of the deep veins can lead to this. High pressure within the superficial system causes local dilatation, which leads to sequential failure, through overstretching, of other nearby valves in the superficial veins. After a series of valves have failed, the involved veins are no longer capable of directing blood upward and inward. Without functioning valves, venous blood flows in the direction of the pressure gradient, outward and downward, leading to a congested leg. The gravitational weight of the column of blood along the length of the vein creates hydrostatic pressure, which is worse at the more distal aspect of the length of the vein. Once venous hypertension is present, the venous dysfunction continues to worsen through a vicious circle. The etiology of varicose veins can be subdivided into three categories: primary, secondary, and congenital. Age is an independent risk factor. Prolonged standing leads to increased hydrostatic pressures that can cause chronic venous distension and secondary valvular incompetence. Primary cause is valvular insufficiency, can be due to heredity, inborn weakness of vein walls. Secondary causes include deep venous thrombosis, which leads to chronic deep venous obstruction or valvular insufficiency. Pregnancy-induced and progesterone-induced venous wall and valve weakness worsened by expanded circulating blood volume and an enlarged uterus can compress the IVC and hinder venous return from the lower extremities. Trauma is another cause. Congenital includes any venous malformations. Clipaltrinane variants and avulvulia. These are caused by venous hypertension rather than by the varicosities themselves. Inframalleolar ankle flare, or corona phlebectatica, is the most common initial manifestation of venous disease. Visible tortuous, dilated varicosities. Edema that spares the metatarsal area. Pain, which is a dull ache that is worsened by prolonged standing and is improved by walking or by elevating the legs. Soreness, burning, aching, throbbing, cramping, muscle fatigue, pruritus, night cramps, and restless legs. Varicose complications that include variceal bleeding, new onset of dermatitis, thrombophlebitis, cellulitis, and ulceration. When assessing the history, include history of venous insufficiency, presence or absence of predisposing factors, edema, any prior evaluation of or treatment. During the inspection, assess for visible, palpable veins. Reticular veins that are non-palpable. Hyperpigmentations and skin changes, which include brownish darkening of the skin, resulting from extravasated blood that causes lipodermatosclerosis. This usually occurs in the medial ankle region but may extend to the leg and foot. Eczema, erythematous dermatitis, which may progress to blistering, weeping, or scaling eruption of the skin of the leg. Telangiectasias and edema. Ulcers of the medial ankle. Palpation. The entire surface of the skin is palpated lightly for dilated veins. Palpate the saphenofemoral junction for reflux. Palpated 2 finger breadths below the inguinal ligament and just medial to the femoral artery. If reflux is present, a forced coughing maneuver may produce a palpable thrill or sudden expansion at this level. Newly dilated vessels sit on the surface of the muscle or bone, whereas chronic varices erode into underlying muscle or bone, creating deep boggy or spongy pockets. Percussion is used to check whether 2 venous segments are directly interconnected. Other maneuvers include the Perta's maneuver, Trendelenburg test. Venous duplex ultrasound has become the standard of care as mentioned in RACGP Guideline. For ruling out deep venous thrombosis, duplex ultrasonography, Perta's maneuver / Linton test, which distinguish antegrade flow from retrograde flow in superficial varices, maximum venous outflow, magnetic resonance venography. Tests for demonstrating reflux, duplex ultrasonography with color flow imaging. Here venous valvular reflux is defined as regurgitant flow with valsalva that lasts longer than 2 seconds. Trendelenburg test that distinguishes patients with reflux at the saphenofemoral junction from those with incompetent deep venous valves. Doppler auscultation, venous refilling time in healthy subjects. The VRT is longer than 120 seconds. Muscle pump ejection fraction. Detect failure of the calf muscle pump to expel blood from the lower leg. Tests for assessing venous anatomy. A duplex ultrasonography, direct contrast venography can be done. For staging varicose veins, the clinical etiologic anatomic pathophysiologic (CAP) classification is used. They have 4 components as shown here. In the advanced approach, additional option that any of 18 named superficial, deep, or perforating venous segments can be used as locators for venous pathology. There is a risk of developing complications such as venous ulcers, deep venous thrombosis, so need to be treated depending on the level in the staging. Uncomplicated veins, without significant pain, can safely be managed with reassurance only. Conservative treatment with stockings and external compression may be appropriate for patients who are too unfit for intervention or those who do not wish to have any form of surgical intervention and who have palpable foot pulses or an ankle brachial index over 0.6. Surgical removal or obliteration of varicose veins is often for cosmetic reasons alone. Non-cosmetic indications include symptomatic varicosities or complications. Before any intervention, duplex ultrasonography (DUS) should always be used to map all major reflux pathways, and a skin marker should be used to mark all surface vessels to be removed. Minimally invasive techniques include cutaneous electrodesiccation, rarely used now. Sclerotherapy, foam with the sclerosing agents, has a better use. Foam pushes blood out of the vein, under ultrasound guidance. A sclerosing substance is injected into abnormal vessels to produce endothelial destruction that is followed by the formation of a fibrotic cord and eventual reabsorption of all vascular tissue layers. Polidocanol and sodium tetradecyl sulfate sclerosing substances are used. Endovascular techniques. Endovenous laser treatment. A laser fiber produces endoluminal heat, with no contact, that destroys the vascular endothelium under ultrasound guidance. Radiofrequency ablation. Radiofrequency thermal energy is delivered directly to the vessel wall by contact, causing immediate closure of the vessel. Cyanoacrylate. Endovenous treatment of varicose veins with N-butyl cyanoacrylate. Patients should not undergo endoluminal treatment if the veins are overly large, greater than 2 cm diameter, overly tortuous, or very close to the skin. Open techniques. Excision of greater saphenous vein. In the current technique, femoral vein and the saphenofemoral junction are exposed with dissection. A stripping instrument is inserted at the saphenofemoral junction in the greater vein and brought out at the tibial tuberosity. The stripper is pulled downward, tearing away from each tributary and perforator. Excision of small saphenous vein. Here sphenopopliteal junction must be located by duplex examination as there is a risk of injury to the popliteal vein and peroneal nerve. Using a stripping instrument the vein is removed. Stab phlebectomy, with a microincision, the vein is delivered with a tiny blade or a large needle. It is repeated along the entire length of the vein. Mechanical, using steam or rotating catheter. Tributary varicosities can be treated either with direct phlebectomy or with ultrasound-guided foam sclerotherapy. Treatment of systematic axial vein reflux should be treated primarily with endoluminal thermal or non-thermal ablation techniques rather than with surgical vein stripping. In postoperative care, the patient is asked to wear a graded compression stocking and make sure they maintain or increase their normal activity levels. Thank you for joining me today as we delved into the world of varicose veins. If you found this video informative, don't forget to give it a thumbs up and subscribe to our channel for more insightful content on various medical topics. Share your thoughts and questions in the comments below. I love hearing from our community. Stay proactive about your vascular health, and together, let's continue on the journey to a healthier, happier you. Until next time, take care and be well.